Hello to all. I am Vishnu. So today I am going to talk about the management strategies of different types of tuberculosis. So this is going to be a bit long presentation because we'll talk about the management strategy of different types of tuberculosis, and along with that we will also talk about how to manage the ADRs due to different anti-tubercular drugs. And definitely we'll talk about delamanid, which is a newer molecule as well. In the last video, I talked about the epidemiological statistics of tuberculosis, but again, it was an old statistics. Actually, I made this presentation 3 years back. So now maybe the guidelines might have changed a bit, but I don't see much of a significant difference. Almost it's the same. So let's go into the presentation directly without any delay. So, management of drug-sensitive tuberculosis. So, this is usually treated by first-line anti-tubercular drugs. So, drug-sensitive tuberculosis means the bacilli, that is the Mycobacterium tuberculosis, is sensitive to all the first-line agents. So, drug-sensitive tuberculosis are of two types. One is called newly treated patients, and the other is called previously treated patients. So newly treated patients means they have got it for the first time in their life. Previously treated patients means they got it before, then they got recovered from it, and they got it again. So if it is a newly treated patient, the treatment involves 2 months of HRZE. H stands for isoniazid, R stands for rifampin, Z stands for pyrazinamide, and E stands for ethambutol. So this comes in the intensive phase. So yesterday I told you about the difference between intensive phase and continuation phase. Intensive phase means we are aggressively treating the disease. Continuation phase means whatever remaining tubercle bacilli is there in our system, that will get flushed out. So in the intensive phase, it is of 2 months therapy. We will use HRZE. And in the continuation phase, we will use HRE. That means Z is not there. As I told you before, pyrazinamide is never used in the maintenance or the continuation phase. So 4 months of HRE. So 2 plus 4 is equal to 6 months of therapy. But if it is a previously treated patient, there is a small change. 2 months of HRZES plus 1 month of HRZE. That means total 3 months of intensive phase. So S stands for streptomycin. So streptomycin we will use for initially 2 months. Then the next 1 month we will not use streptomycin, because streptomycin, as you know very well, it is an aminoglycoside. And definitely you have to look at the kidney function of the patient. We also have to look at the status of vertigo. There is a very interesting factor which I want to share about streptomycin. Streptomycin is the most notorious culprit among all the aminoglycoside which causes vertigo as a side effect. So vertigo is very commonly seen with streptomycin. So 3 months of intensive phase and 5 months of HRE. As I said before, we don't use most of the injectables and pyrazinamide in the continuation phase. So total duration is 2 plus 1 plus 5, that is 8 months. So this is what is mentioned, what I mentioned in the theory, that is what I have mentioned here in the table. So anyways, if you want this presentation, you can contact me at LinkedIn. So there I'll be very happy to be of service to you. I'll be sending you this presentation so that you can refer it on your own. Now we come to management of multi-drug resistant tuberculosis and which are the different principles involved. Multi-drug resistant tuberculosis has a rapid course with worse outcomes, especially if that patient is also suffering from any immunocompromised condition, for example, HIV, or if the patient is on long-term immunosuppressants. And if that patient has got multi-drug resistant TB, the outcome is very poor. So the treatment involves complex multiple second-line drug regimens, but the problem is that the treatment duration becomes longer. Why the treatment duration becomes longer is because the efficacy is low. So lower the efficacy, longer the duration of treatment. It is expensive in nature and there is a high risk of toxicity. You know very well what is multi-drug resistant tuberculosis. In this condition, both isoniazid and rifampin both will be resistant, and they are usually considered to be the most potent first-line agents. So if you look at the general principles of MDR-TB management, number 1, include 4 effective drugs in the regimen. 6 drugs can also be included, provided the efficacy regarding any of them is uncertain, as a backup plan. So what I meant is that, for example, you included 4 drugs in the treatment, but you are not very sure if any of those 4 drugs will be effective or not. So as a backup plan, you can add 2 more drugs to the therapy. But again, whatever drug you are using, whatever therapy you are thinking of, you should always look into cost, safety, and efficacy balance. Always look into that. Avoid usage of cross-resistant drugs, for example, 2FQs. Like for example, if you are using levofloxacin and moxifloxacin in the same patient, that is wrong. Kanamycin with amikacin, that is wrong because both are aminoglycosides. You should not do that. Ethionamide with prothionamide, that is also wrong. Cycloserine with terizidone. Actually, what happens is that cycloserine, the medicinal chemistry, if you look at the medicinal chemistry of cycloserine, it matches to a great extent with terizidone. And that is why cycloserine should never be used with terizidone. Ethionamide with isoniazid, especially if it is a low-level resistance, that also should not be used. I will explain. There is a very interesting feature about the resistance of isoniazid. There I will explain to you why I said this. Whenever you are selecting drugs for treatment, you should select in a hierarchical order. Hierarchical order means you know very well from the higher order to the lower order how you know it is like a sequential order. For example, 2 group 1 drugs plus 1 injectable group 2 drug plus 1 fluoroquinolone plus 2 group 4 drugs. So that is the hierarchy that we follow. 2 group 1 drugs means pyrazinamide and ethambutol, because you know very well what is multi-drug resistant tuberculosis. It means that isoniazid and rifampin are resistant. So definitely you can use the remaining first line agents. So you can use pyrazinamide and ethambutol. Then you can use 1 injectable drug from group 2, which is an aminoglycoside. Then you can use a fluoroquinolone, which comes in group 3, and you can use any 2 group 4 drugs. So what are these individual groups? I have already mentioned in the previous video. Please look into that. You will get what I meant. The standard Rntcp regimen for multi-drug resistant tuberculosis consists of 6 drugs in intensive phase for 6 to 9 months and 4 drugs in maintenance or continuation phase for 18 months. So you can imagine how long this therapy will be. If it is approximately 24 to 27 months, which means approximately 2 years or more. The minimal 6 months of intensive phase can be extended by 1 month each time to a total maximum of 9 months, provided the sputum culture at the 4th, 5th, and 6th month turns out to be positive. So, for example, a person has been diagnosed with multi-drug resistant tuberculosis. What the guideline says is that you should take the sputum culture at the 4th month of the treatment. If the sputum culture is positive at the 4th month, then you should extend the treatment by 1 more month. Then at the 5th month, you can again take a sputum culture. Again, if it is positive, then you can extend it for 1 more month. Then you go to the 6th month, and again, if the sputum is positive, you can take 1 more month. So total you can do for 9 months maximum. Intensive phases of 9 months maximum. If at the 4th month the sputum is negative, then you don't have to worry at all. you can stop the intensive phase at the 6th month, and then you can start with the continuation phase. If the sputum culture is negative at the 5th month, then you can stop the intensive phase treatment at the 7th month or the 8th month. So like that, you have to decide the duration course of intensive phase. And please remember, pyridoxine at a dose of 100 milligram per day should be given to all patients during therapy to avoid precipitation of neurotoxicity. Actually, the maximum neurotoxicity is attributed to isoniazid because isoniazid causes pyridoxine deficiency. But there are many other anti-tubercular drugs which also precipitate neurotoxicity. For example, cycloserine, we have para-aminosalicylic acid, like that many other medications are also there. So generally, you should use pyridoxine. So if you look at the standard Rntcp regimen for multi-drug resistant tuberculosis, so we have an intensive phase of 6 to 9 months and we have a continuation phase for 18 months. So in the intensive phase, we use kanamycin, which is an aminoglycoside, levofloxacin, which is a fluoroquinolone, ethionamide, cycloserine, pyrazinamide, and ethambutol. Once again, ethambutol should not be used in unconscious patients and also in those patients whose age is less than 5. In the continuation phase, we are eliminating pyrazinamide and kanamycin. As I said, injectables and pyrazinamide should be eliminated in the continuation phase. So we are using levofloxacin, ethionamide, cycloserine, and ethambutol. And as I have mentioned below, pyridoxine 100 milligram per day should be added to the above regimen. Now we come to rifampin-resistant TB. So you understand what it means from the term itself. So according to both our WHO and Rntcp guideline, rifampin-resistant TB is treated as multi-drug resistant TB. But the problem is that isoniazid is usually considered to be sensitive. So that is why rifampin-resistant TB is separate. Actually, what happened is that earlier rifampin resistance was considered as multi-drug resistant TB. But now we have understood that if a patient is resistant to rifampin, there are a huge chance that the patient might be sensitive to isoniazid. So that is why now we have a separate term known as rifampin-resistant TB. So in that we have an intensive phase of 6 to 9 months and a continuation phase of 18 months. We use kanamycin, levofloxacin, ethionamide, cycloserine, pyrazinamide, ethambutol, and isoniazid. So we have 7 drugs in the intensive phase, and in the continuation phase, we use levofloxacin, ethionamide, cycloserine, ethambutol, and isoniazid. Again, pyridoxine should be given to the above regimen. Management of monodrug resistant TB. So if you are having monodrug resistant TB, the intensive phase is of 3 to 6 months and the continuation phase is of 6 months. So it is a total treatment strategy of 9 to 12 months. So you can use rifampin plus any 2 of first line drugs which is sensitive to the bacilli, plus 1 injectable second line drug, plus 1 fluoroquinolone. So a total of 5 drugs should be given in the intensive phase. In the continuation phase, we usually stop the injectable drug and we continue with the remaining 4 drugs for 6 months. Again, we should add pyridoxine to the above regimen. If it is polydrug resistant TB, the intensive phase is of 3 to 6 months and the continuation phase is of 6 months. Again, this is a treatment strategy of 9 to 12 months. Rifampin plus 1 injectable second line drug plus 1 fluoroquinolone plus any 1 first line drug to which the bacilli is sensitive plus 1 of the oral second line drugs. That is, it can be either ethionamide, it can be cycloserine or para-aminosalicylic acid. So a total of 5 drugs should be used in the intensive phase. I am sorry it is written continuation phase, but I meant it as intensive phase. In the continuation phase, we should stop the injectable drugs and we should continue the remaining 4 drugs. So this you have to understand in the hierarchical order. Unless and you see, lot of terms are written here like second line drug, first line drug, etc., etc. To understand this, please go to my first video. I have explained very well which is the first line oral, first line injectable, and all these things I've mentioned there based on group 1, group 2, group 3, group 4, and group 5. Please look into that. Pyridoxine 100 milligram per day should be added to the above treatment regimen. Now we come to the most interesting part, that is INH resistant TB. So in order to strategize the treatment for INH resistant TB, firstly, we should understand which are the different mechanisms by which isoniazid resistance occurs. So isoniazid resistance can occur in two ways. Number one, low level isoniazid resistance, and the other is high level isoniazid resistance. In low level isoniazid, there is a gene known as INHA gene. So that actually what happens, it is a very important gene which actually helps in the mechanism of action of isoniazid properly. And you know very well that if you don't know, isoniazid is a prodrug. So it goes into the body and gets converted into an active metabolite. In low level isoniazid resistance, mutation occurs in the INHA gene. So that is why that resistance is called low level isoniazid resistance. So in such situation, the best thing that we can do is focus on using high dose of isoniazid, that is 900 milligram per day. Add pyridoxine to the treatment regimen. Monitor for potential neurotoxicity. Pyridoxine should be added to the treatment regimen compulsorily because we are using 900 milligram per day, and at very toxic doses, isoniazid can precipitate seizures and neurotoxicity. But we should never use ethionamide. Always remember, in low-level isoniazid resistance, ethionamide should not be used because there is a risk of cross-resistance. Ethionamide will become ineffective. So low-level isoniazid resistance simply means that there is a mutation in the INHA gene, as a result of which low-level isoniazid resistance occurs. But it doesn't mean that we cannot use that molecule. We can use that molecule, but at a very high dose, that is approximately 900 milligram per day based on your body weight. Pyridoxine should be given and the patient should be closely monitored for any kind of neuropsychiatric problems or neurotoxicity. High level isoniazid resistance means we cannot use isoniazid at all, because there is a gene known as CAT-G gene. As I told you before, isoniazid is a prodrug. So when it enters into the body, there is a gene known as CAT-G gene. This gene converts isoniazid into its active metabolite. Now, if there is a high level isoniazid resistance, there is a mutation in this CAT-G gene. So obviously you know very well, if the metabolism of a prodrug does not happen, the active metabolite will never be released. If the active metabolite is not released, the drug will never be able to show its activity. So that is why in high level isoniazid resistance, we cannot use isoniazid even at high dose, because the conversion will never take place. The active metabolite will never be released. But interestingly, in this condition, ethionamide can be used, because ethionamide is effective in patients with high-level isoniazid resistance. There is no risk of cross-resistance. So let me tell you once again about the interesting aspects of isoniazid resistance. There are two types of isoniazid resistance. One is called the low-level resistance and the other is called the high-level resistance. In low-level resistance, there is a mutation in a gene known as INHA gene. So in such conditions, you can use high dose of isoniazid. Accordingly, pyridoxine dose should also be increased and the patient should be monitored for neurotoxicity. In such conditions, you cannot use ethionamide because there is a risk of cross-resistance. But if it is a high-level isoniazid resistance, there is a gene in our body which is known as CAT-G gene. This helps in the conversion of isoniazid to its active metabolite. But if there is a high-level isoniazid resistance, this conversion will never take place. So the drug will never be able to show its pharmacological activity. So in this condition, you should not use isoniazid, but ethionamide can be effective. Now we come to the most dangerous type of TB, that is extensive drug-resistant TB. This is extremely difficult to treat. In this condition, we have to use group 5 drugs. If you refer my past video on Rntcp guideline part 1, you would have seen that group 5 drugs are also known as unclear efficacy drugs, because the efficacy is not clear and definitely the side effects are notorious. So to prevent further progression of resistance, we should stop the standard multi-drug resistant regimen immediately. Since group 5 drugs are both costly and toxic, an expert clinical panel may decide on appropriate drug selection. So it is very simple. We have to look at the risk versus benefit ratio. So according to Rntcp guidelines, 7 drugs should be used in the intensive phase for 6 to 12 months, and 6 drugs should be used in the continuation phase for 18 months. So just imagine this treatment is approximately of 24 to 30 months. So almost 2 to 2.5 years. So in the intensive phase, we can use capreomycin, moxifloxacin, high dose isoniazid. Please remember, if you are using high dose isoniazid, we have to monitor the patient for neurotoxicity. Para-aminosalicylic acid, clofazimine, as you know, it is an anti-leprotic agent also. Linezolid, it is an oxazolidinone antibiotic. And amoxicillin clavulanate, 2 tablets in the morning and 1 tablet in the evening. This has to go for 6 to 12 months. In the continuation phase, it is for 1.5 years. There we are using moxifloxacin, isoniazid high dose, para-aminosalicylic acid, clofazimine, linezolid, and amoxicillin clavulanate as usual, 2 tablets in the morning and 1 tablet in the evening. Here we have eliminated capreomycin because you know very well that capreomycin is an injectable medication. We do not use it in the maintenance or the continuation phase. You should add pyridoxine at least 100 milligram per day. As I said before, anyways, we are using isoniazid high dose, so pyridoxine should be used. If you look at the daily dose of first-line anti-tubercular drugs as fixed dose combination tablets, you know very well what is fixed dose combination. If multiple molecules are there in a single formulation, it is called fixed dose combination. So based on your body weight in kilogram, in the intensive and the continuation phase, how many tablets should you use on a daily basis? So if your body weight is in the range of 25 to 39 kilogram, in the intensive phase, you can use 2 tablets, and in the continuation, you can use 2 tablets. If your body weight is in the range of 40 to 54 kilograms, intensive will be 3, continuation will be 3. If your body weight is in the range of 55 to 69 kilograms, intensive will be 4, continuation will be 4. And if your body weight is 70 kilogram and above, intensive can be 5 and continuation can be 5. So for the intensive phase, each tablet, the number that you have seen 2, 3, 4, 5, this is the number of fixed dose combination tablets. So each tablet contains isoniazid 75 milligram, rifampin 150 milligram, pyrazinamide 400 milligram, and ethambutol 275 milligram. And in the continuation phase, we have eliminated pyrazinamide. So each tablet contains isoniazid, rifampin, and ethambutol. Daily dose of first-line anti-tubercular drugs based on body weight. So if it is isoniazid, the daily dose should be approximately 5 milligram per kilogram. And in bracket, what I have written is the range. Rifampin can be 10 milligram per kilogram. Pyrazinamide 25 milligram per kilogram. Ethambutol 15 and streptomycin 15 milligram per kilogram. per day. If the patient's age is greater than 50 years, the maximum dose of streptomycin will be 0.75 gram per day. That means 750 milligram per day. Because as your age increases, there is a risk of nephrotoxicity and vertigo, which is usually seen with streptomycin. So the dose should be fixed. It should not go above 750 milligram per day. So this is regarding the topics that I discussed today. Tomorrow I will talk about treatment of patients with ADR to anti-tubercular drugs, and definitely about delamanid, which is a new molecule. It's not new now, it's like 3 years old, but still I'll talk something interesting about that. So that will be the last part that I will be sharing tomorrow, which is the part 3. So I hope that you have got sufficient information, and I hope I have been of service to you. If you appreciate my efforts, then please do subscribe and share this to maximum people, because as I always say, knowledge is power, and knowledge shared is knowledge doubled. If you want this slide, please contact me. My name is Vishnu R. Nair. You can contact me in LinkedIn. If you want this slide, I'll be giving you there. Or you can comment your email ID in my LinkedIn. I can share in your email or however it is. So thank you so much for listening. We'll see you in the part 3 video tomorrow. Until then, it's goodbye.